post-op, 3 months post-op on top, bottom. And I have some slides of this, but I want you to try to get your head into this. This guy really likes the way that his immediate dentures look. I mean, he really likes them a lot. So instead of going back to wax rims and all those things that remind me of dental school a little bit too much, I like to take the patient's immediate dentures that we made already, these guys, and we put these in a denture duplicator. We make a copy, carbon copy of the upper, carbon copy of the lower. And then what we're going to do is we're going to take our closed mouth impressions with that in order to create the final prosthetics. So the lab knows where the teeth are set. I have some slides to show this so to make more sense. But the lab knows where the teeth are going to be set. They know what the vertical is. They know the inter-incisal relationship. They know the midline because all that's been established in the mediates. So why throw all that information away? Why not take those immediate dentures, make a carbon copy of them, and use those as your custom trays? Does everybody follow that? So it's kind of like if you told the patient, hey, I need those immediates for a couple weeks, all right? And I'm just going to use them. I'm going to take some impressions, and the lab's going to mount the case up, and they're going to set the new teeth based on right where the old teeth was set. And they're going to make a carbon copy of what I sent them. Then I'm going to give them back to you. Well, instead of doing that, they're not going to go without their teeth. If we duplicate those in a Lang denture duplicator, which really is a clamshell with alginate, you know, and you slam it together, and you open it up, pour acrylic in it, slam it back together, and you have a carbon copy. And now you've got a way to make a custom tray that is going to be exactly the same as what was with their immediate denture. So what I want you to see here is we've got metal framework incorporated into this is the upper, and we've got relief over all 4 locator attachments. Then we're going to mix up Fit Check, which is a quick setting polyvinyl siloxane, and we're going to seat it in the mouth and make sure that we're not bottoming out on any of these locator attachments, because this is a tissue-borne prosthesis. It needs to be sitting on the tissue. You don't want this holding it from seating all the way. We pick up most of our attachments in the mouth. I know that the lab can process the attachments into the denture. I haven't had real good luck with that. And one of the reasons is if you have a model, you've got dynamic soft tissue, and the model doesn't represent that. The model is a static thing, and so is the implant itself. So you wind up with a less than perfect hermetic seal. Sometimes those overdentures are riding up on the implants. This is the way that we can make sure that this thing is sitting on the tissue and this is not in the way. So once we've established that, and we know that we've got enough room for our attachments, then we can come back and use cold cure acrylic, put these in the mouth. One of the things I do now is I sandblast these things because this is a real polished finish on these things. So we'll sandblast them ahead of time, put them into the mouth. We've already taken our new prosthetics. We've made sure that there's enough relief to where they're sitting passively, and we'll put these little washers around there so that none of the acrylic gets trapped underneath here. And then we'll go ahead and no retention at all, let them get the hang of it. Then we'll pluck those out of there and go to using a blue, or sometimes we'll put 2 clear in the back, 2 blue in the front, just depending on how much retention they want, and just depending on what their hand strength is. So here's the upper with the metal framework in it, just the final case. And you have to have metal frameworks in these things or they're going to break. So that's one of the reasons why we'll make immediate dentures, and I just tell them, those immediate dentures, we're going to use to determine your bite, aesthetics. You have teeth to wear while you're healing. And if we want to make any changes, we'll use that as our set of blueprints. A lot of times, the immediate's pretty right on. So if we just duplicate the immediate, take our impressions, send that to the lab, we ought to be able to wind up with a carbon copy of what was there before, with the exception being the insides of these things are going to have a metal framework reinforcement. Yeah. Yes?
Do you use extended range in those usually? In those locations?
You know, I'm going to tell you the problem. The problem with extended range, and let me pull this up. The problem with the extended range is that it only gets its retention from the perimeter. So what will happen is it'll wear out the perimeter, and then you got to go in the mouth and replace these things. So I only use extended range when we've got some lack of parallelism. And if I got one that's way off, I'll get a locator attachment from Implant Direct, because they have some that are offset, you know, to bring it more into alignment, like an anterior maxilla. But the extended range, what I find is you would think that if you got a piece of plastic snapping on to a titanium abutment, you would think that the plastic would wear out, but the titanium would never wear out. Well, the truth of the matter is, and I don't know how many people have experienced this, I've seen it a bunch. Some of these patients, I don't know if they leave toothpaste in their mouth or what they do, but they will wear that titanium out. Have y'all seen that before? Anybody? Okay. It's a bummer because, you know, you keep changing the snaps out. It's not tight, it's not tight, it's not tight. And one day you look in there, and there's no gold around the perimeter of the attachment. It's all silver, and you know that you've got a bunch of wear going on. This is the, I'm going to show, since we're on the subject, I'm going to bring one of these up so you can see what it looks like. So, we got to be careful about a lot of the information that's out there now, and I'm just going to point out some specifics, and then we'll get to the thing I was just talking about with the locator attachment. When EagleSoft 16 came out, boy, they promoted the hell out of this. And I get on Dentaltown, beware, there's not much support on their end for this. It wouldn't load correctly. Process took 2 hours, and we've only been open for 6 years. Accounts receivables all screwed up. I mean, we really have to be careful. We're beta testing for a lot of people out there. The other thing, you know, all this, and I use Dentaltown as a sounding board because you find out what's the real scoop on a lot of stuff. Here's the EagleSoft 16 is a major RAM hog. We can't be running anything else on the server while we're running EagleSoft. Man, it's good to know that, you know, because, you know, we rely on this stuff day to day. And so I go to Dentaltown and find out what's going on. You know, there's a lot being written about adhesive retained all ceramic posterior restorations. You know, I go on Dentaltown. I had 2 debonds on my schedule today, both with flat top preps with very little mechanical retention. It's probably 5 debond. You know, I mean, you start finding out people are having some trouble with some of this stuff. And, you know, this guy's doing CERAC, and he's doing all this stuff. And, you know, and then when it comes to endo, Kathy, I don't know where to go with this, you know. This is a remarkable implant called Mini-Mark. And this is what we're seeing happen in some patients. And this is taken with iPhones, so it's not real clear. But if you look at this, you see all this? It looks like somebody got on there with an emery board. And why is this one still look good and this is all banged up? Well, this won't retain anything. You can take a brand new locator attachment and snap it on there and it just fall right off. So if you have a case that's not stable, it's not staying in the mouth, go back and look real hard. You may have to replace the abutments. And the scary thing is, the patient just paid all this money and it's been a year, and now they have 4 locator attachments and all 4 of them are worn out. 4 times 130 or 140. You know, who's going to pay for that? You are, I think. If the patient has to pay, it's not going to be good. So I just want you to be aware of that. This is done in Baton Rouge. This lady whose daughter was working for a dentist that went to a mini implant course. And I'm going to just tell you, I think mini implants have a place. I don't do very many of them. I do one every now and then. I did 4 on a lady the other day. She was from New York or something like that. She had 4 tapered screw head implants, horizontal bone loss all the way across, lost all 4 of them, made her a regular dent. She can't stand it, doesn't have any money. And I said, look, I'm going to get you in and put these little 4 things in. She's 80-something years old. I said, you're going to get some, you know, this is going to work out fine for you. But that's not my go-to, and definitely not for this. So what happens is this thing breaks off. So we get it out of there, put this in. And then later on, see what happened later on. Later on, she had to lose this tooth. So you can see we're evolving. Straumann, AnyRidge right here. She had to lose this guy right there. And then this thing wound up breaking off later on. This is a case I did. See right there? Broke off while I was inserting it. You know, good dense mandible, snapped off. Up here, sinus lifts, implants, locator retained bar on the top. It's a case I did on Betty Moe. And she didn't want to have implants done. She needed keeping a lower 4 anterior teeth. I said, well, let me put these little minis in on each side so we can snap the partial in and we won't have any clasp showing. This snaps off. After a few years, it doesn't happen overnight. So I go in and put another one in, and I don't remember what happened to that one, but it didn't work out. So then I put a real implant in with a locator attachment, and I paid for all this. So some of my lessons have been expensive ones. I got this from a dentist in Monroe. Jeff Hanselone sent me this. He goes, what do you think about this? The patient comes in and says, my tooth is loose and my lip is numb. You know, that's, I'd say that's malpractice, you know. Now, this is a guy, Jimmy, this is one of Vic's patients, a guy from home, Louisiana. We did this 10 years ago. It's in the maxilla. Man, it's really worked out well. It really has worked out well. But statistically, this is going to fail at a much higher rate than conventional implants will, particularly in the maxilla. Before they came out with 3 millimeter AnyRidge and BioHorizon implants, in cases where we didn't have enough bone width, we certainly had enough room between the teeth, but we didn't have enough width, you know, we would resort to using mini implants and then trying to make crowns over those things, which is kind of a pain. It's so much nicer when you've got an implant with a custom zirconium abutment, and then your lab is not trying to opaque out any kind of metal color. They're making a real nice Emax crown. It's going to look better than this is going to look, you know, over the long haul. And even here, these are some mini implants from a company in Israel, which we've used also. But the thing I want you to see here is this patient's already gotten out of braces, and they come in and the orthodontist goes, hey, look, did the best we could do. It's the best we could do. So what are you going to say to that, you know? And so in these kind of cases, we'll make a very small pilot entry, and then we'll thread this bone spreader, and it'll go ahead and find the path of least resistance. So this is all done with a motorized bone spreader on 50 RPMs. And these cases have really worked out well. They're not fun to do, but they've worked out well. And when we talk about peri-implantitis, these are Calcitech implants that were done 20 years ago. I'm getting ready to redo the restorative. These have been in for 20 years. HA coated, you know, those things can get kind of nasty sometimes. This has been in 2 or 3 years. Got this going on, that going on. Disaster. He keeps a cigar in his mouth 24 hours a day. I mean, when he comes in, his denture's black, and he's such a nice guy. What I just showed you was, this is second round. We've replaced these implants since then, and the ones I've put in there are going south also. This was done in 1987. What you can't see is on the Panorex, we did some HA-coated implants and a bunch of other stuff. This has been our best result. These are Corvette implants that were done, you know, when we cemented these abutments in. You know, it's just old school, but look how well this is held up. And I guess the point is, you know, it's only going to be as good as the host resistance. You know, in other words, good dentistry is only going to be as good as the host resistance, and bad dentistry is also. So this is not ideal stuff, but it's worked out real well because this lady's just not prone to peri-implantitis, and she's done a nice job. So we'll look at, you know, this is a really good publication by Schwartz and Becker on the peri-implant infection. It's a great book. You know, the jury's still out on what's the best way to treat it. What do you do to clean threads? What do you use? Citric acid? Okay. Have you tried any of those titanium brushes yet? The Salvin Dental has these real long latch type, real small, the end of it is a real small titanium brush. I don't have a picture of it. But you can get into an area, and we'll look at it in a minute, to clean the threads off real well, then use citric acid or tetracycline, and then graft these. But the point that I want to make here is this dentist Tarnow is saying 30% of implants have some degree of peri-implantitis. And I really think this has become a bigger and bigger deal. If you want to watch his lecture, he's got a 4-part lecture on dental XP that it really is good. I'm a real fan of this guy. And this is kind of the sequence that we follow, you know, here's our peri-implantitis. We'll do our conventional mechanical debridement, microcin rinse, or use microcin gel and a rotodent, even Clorox, whatever it is, we've got to kill these bugs, or chlorhexidine. And if it doesn't get better, then we start looking at what do we've got. Do we have supercrestal component, interbony component? We're going to do regenerative therapy if the bone loss is less than 2/3 of the implant length, or if the implant's lost integration, obviously we'll take it out. But I can tell you, if they've lost half the bone around an implant, I'd rather just get in there, jack that thing out, and put another one in there. If we do regenerative therapy, we used to use a microetcher with glycine. Now I'm using this, and I'll show that in a minute. Now I'm using these titanium brushes, tetracycline for 3 minutes. We irrigate with microcin, which is it's like a chlorhexidine, but it's better and it doesn't stain, so the patient can use it as a rinse. Not really commercially available yet, but it will be real soon. And then if we're going to go ahead and do some grafting, we use fusion autogenous bone in a collagen membrane or PRF or calcium sulfate. Systemic antibiotics, I have them use Peristat or Oratia, and have them use a rotodent with microcin, rinse out with microcin, and microcin they water pick after they heal for 2 months. And then it's just a crapshoot as to whether or not it's going to work out or not. These are just some really good textbooks. One of them is by Sklar, it's an oral surgeon from Miami. Carl Misch's 3rd edition. Unfortunately, it doesn't look like he's going to be around a lot longer. Huh, Jim? He's asleep. Jimmy. Let's talk about Misch. He's not doing too good. Yeah. But a lot of good publications out there, good reference books. If we're going to do an extensive case, the first thing we want to do is try to get the aesthetics. We'll do this in this particular case with a denture. Then we can go ahead and duplicate that denture, use barium sulfate within the duplicate so that when we do our scan, we can see where the teeth need to be so that we can develop these guides if we choose to do guided surgery in a case like this. Here's a guided surgery case. And this was done a number of years ago. But what happens is I get the guide back and I put it in place and I'm thinking, you know what? I don't want to drill through that soft tissue. And secondly, I'm not sure if I trust this thing, so I went ahead and flapped it anyway. But I got real good mesial distal positioning. And it's like, God, that was a lot of trouble just to put the hole right in the middle of 2 teeth. And I knew from the scan that I had an invagination up here, so I got to graft those areas anyway. Okay, so there's a lot of trouble and a lot of expense, and I wouldn't do that again today. I just don't find the need for it. So if we're going to look at success, background training, experience, consultation with other practitioners, good records, good case presentation. We'll talk about that after lunch. Good management of the healing provisional phase. And like I said, I'm a big fan of immediate provisionals. We've had real good luck with them. And excellence in implantation of the restorative phase. Because, Savoy can do a perfect job, but if somebody's using a crap lab or they don't know what they're doing, you get all done and the patient doesn't like the way the tooth looks, it's a failure. If they don't like the aesthetics of the case, it's a failure. Patients keep raising the bar up every year. I mean, that's why I'm glad I'm 60. Because, 10 years from now, it's going to be out of control. You're like, hey, look at this. I can see a line back there. It's like, come on. You want me to make a tooth that, like Howard Ferrand said 2 weeks ago, they say, you want me to make a tooth exactly like God made? Exactly like God made? We can't do that. We can get close, but we can't make it exactly like God made it. So quit asking me to do this stuff, If you go to this website, drsmithsite.weebly.com, the techniques for implant stent fabrication, all the materials, the drills, the drill press, the sleeves, all that information is on that site. So this is the 5-speed drill press. Make sure it's only a 1/3 horsepower. I don't know if that matters. But it's from Harbor Freight. It's like $60. These digital calipers we get from Harbor Freight. They're $19, or you get them from Salvin for $140. Same thing. Same exact thing. 1/16 inch high-speed titanium drills, which is what's used in the drill press. This is an adjustable surveyor table, okay, that you see right here. And this is the company that it's called Microgroup, where we get these titanium sleeves from. And I already went through the series of how we make the stents using the drill press and so forth. But instead of trying to memorize all this stuff, you just go to that site. There's a bunch of information on that site relative to the stuff we're talking about today. Okay, Dr. Smith site. .weebly. WEEBLY.com. Weebly is a website where you can develop your own websites. It's real easy to do. And if you want to register and pay money every year to have a site without Weebly in it, you do that. Or if you just Weebly, I have like 8 websites, and they're all at that address. Okay. Somebody asked earlier about sinus lifts. I think you did. I use this thing right here. It's a Crestle approach from Zimmer. Blue Sky Bio has the same thing for a lot less money, but same thing. And basically this drill, when you're coming through this bone, when you get near the membrane, it's pushing chips in front of it, and it'll, unless you push real hard, if you use the drill stops and radiographs and judgment, you'll be able to elevate this membrane without perforating it through the osteotomy. It's really pretty slick. It really is nice. So here, as you pilot drill, then you go right up to the antral floor. Then you move it, you stop back a little bit. Then you finally get through. Then you go ahead and inject your bone material through the osteotomy. This kind of breaks it up. It's kind of like a little corkscrew, little paddle wheel, all kind of cute little things. But it enables you to be able to get a nice elevation through the osteotomy, and it prevents you from perforating. I like this kit because this is for the lateral approach, and same kind of drill design, but just a little bigger in diameter. And so you can drill these windows, and then you can elevate your membrane away and go ahead and do the lateral approach, Caldwell approach to sinus elevation. So here we are. We flapped the maxilla, made our window, elevated the membrane using the little elevators, sinus curettes that they supply you with. Then go ahead and add your graft. And it's really pretty slick. I mean, in fact, they brought the kit to the office and we were doing a course the next day, and we just did a case with it. It went perfect. So it's really easy to use. Yeah?
What's the minimal amount of bone if you're doing a crustal approach to put the implant the same basis?
It depends who you ask. I've been doing it with 3 and 4 millimeters. That's not much, but I would only do it with the AnyRidge implant. Like a tapered screw band or something like that. Those AnyRidge implants engage that minimal amount of bone so well that you have such extraordinary initial fixation that you can get away with it. Whereas I like to let those heal for a good 4 or 5 months. I'm not in a hurry. I always tell patients, the only way we get in a hurry in the implant dentistry is we try to do everything too fast. We just take our time and be patient. We're going to wind up with a better result, and that's why I like immediate provisionals, because then they quit bugging you. And so in a little while, we'll talk some more about using fusion. And if you want to order fusion, you can get it from Woodland Hills Pharmacy. You'll see the slide in a minute. They're out of Houston, Texas. And it's like $15 a dose. It's $30 if you just buy one, but if you buy like 10 or more, it's like $15 a dose. So it really is priced very well. So if we look at a situation like this, we took this tooth out, grafted with fusion bone binder, freeze-dried bone. Then after 3 or 4 months, we come in, elevate the membrane again through the osteotomy, and wind up with this nice, long, wide diameter implant that goes into what was formerly this site right here. Same thing down here. These teeth have to be removed. There's our nice grafted site. Here are these nice implants that were placed several months down the road. Here's another one, immediate extraction, antral elevation, bone graft. Here, these 2 implants placed at the same time.
You ever use the fusion by itself?
No. Some people in Dentaltown have said they have, but I don't think it's a good idea. I think you want to get freeze-dried bone in there with bone morphogenic protein and all that stuff. I don't pretend to remember all that science all that well. I'm at the point where it's like, just show me what works. And like PRF, everything I just talked about, I can't tell you all that much about PRF. I have to have the screen up to say, oh, leukocyte this and fibrin that. But I just know it works, and I'm not real interested. I don't know how an Apple phone works, but it works. And that's all I care about: what works and what doesn't work. And that's a lot about what today is about. Is just based on the experiences we've had. This is what's working. This is why we're talking about AnyRidge. I wasn't talking about AnyRidge 4 years ago because it wasn't invented yet, and now it's all we do. And it's good that I'm glad to see that things have improved so much. You think about, when we were kids, you go to a hotel, you put a quarter in a bed and it would vibrate, and that was like a big deal. Well, nowadays, beds, they got rollers in them and massage things and heaters, and you and your wife can be at different levels and different softness. I mean, everything is just is so out of control. It's just amazing to me. This going back to the anodize that I was showing you a little while ago. Really simple deal. Chemistryfordentistry.com. Interesting guy. We'll look at her case in a minute, a little later. Like I said before, if y'all are taking digital photography, I don't know what you're using to develop your pictures and to store them and to organize them, But Picasa is a free software application from Google. Just go to Google, download it. It's awesome. I mean, when getting ready for a course like this, I got millions of slides. I can just scroll through there like a Rolodex and say, there's that case. I can't even remember the guy's name, but I found it because it's just a neat way to organize things. You can crop your pictures, you can lighten them, you can darken them, you can change them to black and white, you can rotate them, you can flip them over if it's a mirror shot. So it's, you know, we used to recommend using Photoshop, which is hard as hell to learn. This is really, really nice. It really is good. So I will use Photoshop in a situation like this to try and image a patient, to show them this is where you are now, this is what we could wind up with, you know, kind of give them a little hope. This is after the case is finished. But we will present cases, and it sounds a little formal, but to me it's been a good means to an end. Somebody comes to me for care, I want them to accept treatment because I've spent all these years learning how to do all this. I'd rather do this and work on kids. We don't see kids in the practice. You know, I have all these things going on in my mind about why I want them to get this done. It's not even to make a good living anymore because I've done well in dentistry. And that, the funny thing is, and Ed and I were talking about this a little while ago, you know, you work hard enough for a long time and they say, man, now I can retire. It's like, well, then what am I going to do? So, you know, the thing that jazzes me about this now is that we can do so much now for people that we couldn't do years ago. To me, the whole idea of losing 13 and 14 and then having to have a 4-unit bridge from 11 to all the way to 15 is like, oh, get out of here. Well, no, I'm sorry. I lost a man who worked on it in dental school, and then it broke off at the gum line eating a crackling. So 12 is not good. So now I'm looking at a bridge from 15 all the way to 11. And you know damn well, you know, when I'm at work, man, I clench like crazy because I want to kill almost everybody that works for me almost every day. And so that's going to have a limited life expectancy. So to me personally, have gone through this is like, man, this really is miraculous. These teeth feel great. I mean, and it didn't even hurt. It didn't hurt like the root canal that was done, you know, that it was done twice, and then the tooth was removed. So I feel like if we can use case presentation to get people to see their problems and then their solutions real vividly, it's a done deal. Unless they absolutely can't afford it. Then it comes down to, well, they can't afford it. It's a single mom, this and that, and this and that. Well, we've got it to where we're so efficient now, I can give her a break. I'll give her 20% off. You know, I don't have any school loans left, and, you know, the house is paid for, and hopefully my wife doesn't want any more, you know, bling anymore. I think she's done with all that stuff. She's got the shingles, got mine occupied right now. And so, and Joel and I were talking about this last night. We have this wonderful thing we can do for people. We got to figure out how to make it a little bit less expensive. You know, and that's the real challenge. Because there are a lot of people, you know, I had a high school teacher that moved down from West Virginia. He's got a doctorate in theology. He's going to work for our local Catholic school. The headmaster calls me and goes, hey, look, he went to see your partner. He had the implant done up north. Now he needs a crown done. Your partner quoted him $1,700. I said, well, you know, those are our fees and this and that. But I said, look, I'll cut him, you know, I'll cut him a break, 30, 40%. It's no work. I'm just going to take an impression. I'm going to send it to the lab. They're going to make a custom abutment. They're going to make the crown, and then we're going to bolt it in. We're done. There's no work involved. You know, it's not like, you know, putting 7 stainless steel crowns on a kid that's awake and vomiting on you. And, I really, right, Jimmy? and so, you know, so if we can get them, and then these people get the work done, and they oh, you're wonderful, and then they send other patients, and we don't advertise. I don't have anything against it, but I'm just saying we don't have to because this is what works for us. Is let's take good photography, develop it in Picasa or Photoshop, show it to them in PowerPoint, incorporate digital radiographs and cone beam imagery into the case presentation, then they just understand it. I don't give a shit if they get the work done at all because all I care about is I'm your consultant. I'm going to explain to you what's possible today in a fashion that you'll understand, and then you're on your own. You're on your own, you know, and some people don't get it done. You know, some people go somewhere else, but most do get it done, and so I'm adamant. And then the other thing is on the website, if you go to patientanimations.weebly.com, you'll find a website that's got all this stuff on it because I don't know where this girl is, you know, in my computer system. You know, she's somewhere in there, but I don't remember her name. I remember doing the case. So we went and found all of our good cases that represent everything we do, and we put it on the website. So when Tammy has somebody that comes in that's missing 4 front teeth or 3 front teeth, needs to have implants in a fixed bridge, she goes right to the website, fixed options, and shows this case. And then the patients get it. You know, she went through braces.